So hello everybody. I'm here to talk with my friend Aseem Malhotra. He's in London, and your left side of your screen, I'm in Florida here, and we are going to talk about science applied to medicine. Aseem Malhotra is an advocate to rationality in medical thinking, and we're going to talk about this and also about his life, his role as somebody who always call attention to important things regarding the medical field and health and everything. So, Asim, thank you for coming to our meeting.
Pleasure.
And
Always a pleasure, Lewis, to
yeah,
speak to you.
thank you. And you're becoming very famous in Brazil because of our videos and everything. So people like a lot to hear your ideas, and it's very entertaining too. It's not only to talk about science; it's very entertaining to talk about you. So thank you for this, intellectual friendship you've been developed for over these last
No, the
years.
feeling's mutual, Lewis. It's a team effort here.
Yeah, so I will start this discussion with a nice book I'm reading. The book is called Medical Nihilism, and it's from Jacob Stegenka, and he's a philosophy of science. He's not a physician, but he studies philosophy of science, and he applies this idea uh, regarding the medical field. And he defines medical nihilism as the view that we should have little confidence in the effectiveness of medical interventions. So, what's your comment about this?
Yeah, I think he's hit the nail on the head. The perception out there, Lewis, for most doctors, probably, certainly most of the public, and even maybe myself for most of my career, is the maybe an exaggeration of what modern medicine can achieve in terms of its effects. And just to put things in context, there's a very interesting paper which I read, which looked at the increase in life expectancy in the last century, which we've added about 30 years on average in the Western world to our life expectancy. When you ask most people, most members of the public, what do you think had the biggest contribution? Most of them say modern medicine. They put that at the top. When in fact, modern medicine has achieved, certainly in the last century, very little, maybe about 3.5 years. And even then, it's pretty much down to acute treatments, things like antibiotics for infections, emergency care, vaccinations certainly come into it. But most of what we're having to deal with today in the modern day, Lewis, is dealing with chronic diseases using medications where the effect size is very small, is marginal. And that's before we even get into issues, indirect, undesired side effects, etc. So I think from what you said, I look forward to reading this book. But it sounds like it's a very good place to start.
Yeah, and actually, there are data showing that physicians overestimate the effect size of our treatments and the beneficial effect of tests or screening, while we underestimate the harms. So it's kind
Lewis,
of
it's
a
very, it's,
not
it's
economical way of thinking. It's demonstrated in human beings and also in physicians.
Yeah, Lewis, you're absolutely right. I think there are so many examples of this. Even this week, for example, I saw several patients who were elderly, people over the age of 75, in my NHS clinic, who potentially were getting side effects from statins. And I was going to test to see whether their lethargy, their muscle aches were because of the statin pills they were taking. But before even getting to that point, they were under the impression that they needed to take their pill, that it was life-saving for them. And when I had a shared decision-making conversation with them based upon the best available published data we have, there is no reduction in all-cause mortality for elderly people, certainly without vascular disease, taking statins. All of these people were in that category. And I explained that to them, and they were, I'll be honest, very unimpressed with the benefits that were much, much smaller than they had anticipated. And that helped at least have that discussion that it was safe for them to try stopping the statin for a few weeks to see if they felt better. But also then bringing back to a discussion with their own doctor, their own GP, about whether they needed to have that. And that's, again, as we've discussed this before, it comes down to transparent communication of risk, which actually is not the default way of modern medical practice. from what I hear, certainly from my own patients, is that this is not something that goes on routinely. Discussing the absolute individual benefits for patients, so they can have a much more clear understanding of what these drugs are achieving, and that's something we need to advocate for.
Yeah.
You've mentioned this issue about the evidence. You're absolutely right. There's a lot of literature and evidence about even how doctors overestimate massively the benefits of screening or the benefits of medications. But that literature has been around for a very long time. So why are things not changing? And that's because the system is defaulted actually to work against what I believe is true ethical practice of medicine. And what we need to do is we need more advocacy. We need more doctors to be advocates to really get that information out there in the best possible way. I have my own view and own role. I've been working on this for a long time to get that information out to as many people as possible. And the ultimate platform for that is mainstream media. And mainstream media doesn't just influence the public; it influences doctors as well.
Right. So we should be able to speak with the public in a more rational sense. And the media like to give news or things that are like miracles, and people like to hear this. So we must be advocates to more rationality. Another problem I feel, I agree, it's a ecosystem problem regarding, almost fake news we have or overestimation of effect, but it's also a biological problem in terms of that the human mind doesn't think probabilistically. It's not the natural way of the human mind to see things in a probabilistic way. We see things in a dichotomous way, yes or no. So when we say we're prescribing a medicine, we physicians and patients and everybody tend to think the number needed to treat is 1. That's the natural way of thinking, biologically speaking. So this is one of the characteristics that makes the matters worse. So there are conflicts of interest, problems with the ecosystem, but also biological problem with the human mind. So we have to train to think scientifically. It takes more effort. It takes more energy to train this way. For example, in a skeptical way, probabilistic way, it's all about training. And we have to be very attentive to our cognitive bias.
Point, I think that's something that probably should start in school.
Right.
We should learn about these basic things. I mean, we all do mathematics at school. We all do statistics, but somehow we haven't applied those basics to how we even practice medicine. And I think it's not rocket science. This is, most people can understand it. And interestingly, I think one thing that surprises my patients sometimes when I have this discussion, and it causes some confusion amongst the public as well, because they'll say, well, hold on, but my doctor says this, or this doctor says this, or I may have people posting on my Facebook, and I'll say something about lack of effect or very small effect. But my doctor says this. So what I do in talks now as well, when I give talks about evidence-based medicine, I start from a position saying, let's just start with a clean slate, and also understand one thing. Most doctors probably don't even know this. One of the barriers to change is lack of knowledge. And there was a very nice paper by John Ioannidis called, it was based upon the medical misinformation mess, and what to do about it. And he cites one bit of evidence that suggests that 70% of healthcare professionals, and this included doctors, academics, failed a very basic, simple test on understanding of evidence-based medicine. So I think we also have to, for people listening to our conversation, a lot of what we are discussing is not something that is naturally ingrained within the minds of most medical practitioners. Right. And that's another barrier to changing the culture.
And I think that rule-based medicine or guideline-based medicine or medicine based on rules, indications, class 1, class 2, things like this, put us apart from the probabilistic way of thinking. Yes. Because we tend to think that if we obey that rule, we are going to make the correct attitude or choice. And it's all about probability. It's impossible to know what's is correct or wrong beforehand. We may take a very good decision, but it's wrong if we afterwards realize the patient died because of our prescription or our surgery, even if it was the best choice and more rational choice at that point. But these rules or guidelines and things like this put us apart from thinking probabilistically.
Yeah,
And
yeah, and Lewis, and I think that especially it varies in different countries, but actually, as you say, these so-called rules and guidelines, they are by their nature, they are conflicting with the ethical practice of medicine. Because if, as you say, we're looking at things in a black and white perspective, that you should do this, you should do this, it actually removes the shared decision-making conversation from the patient. And therefore, in my view, that is unethical. That is ethically dubious. And that is another barrier to change, because doctors themselves will not want to go against the guidelines. People like you and I have confidence in ourselves. We know, we understand this issue. And for me, for example, I was recently in Australia and giving talks around several cities in Australia. And I was asked by doctors, what do we do? Because our guidelines are saying this, whether it becomes to even prescription of statins. And I said, well, the guidelines are unethical. The guidelines are unethical. You have to realize if you're also being financially incentivized to prescribe a statin on a threshold of risk, which removes the way of that conversation of shared decision making, that is unethical. Let's just call it out for what it is. So the rules need to change as well, Lewis. That's the problem. There may be even when it even comes into regulations around how approval of medical devices, or even the FDA approval of how drugs are allowed to be prescribed. In a much deeper level, there may be many issues and flaws with the evidence. But I think there is also a failure of regulation. So we need to think about, and this is maybe a topic, a completely separate discussion, but I'm just throwing the concept out there, that there is something wrong with the legal framework on the prescription of medicines in different countries, and that also needs to change.
yeah, I think there's a golden rule. The rule that we should follow is the concept that is proved by good piece of evidence. And the rule for a treatment, for example, if you are speaking about a treatment, it's the relative risk reduction.
Yeah.
And this rule can be applied to different patients, identifying his or her own beneficial effect, a very particular one. For example, the NNT is not a rule. The rule is the relative risk reduction. So, and it's very interesting. It's really a rule because the relative risk reduction tend to be the same among different type of patients. So, statin therapy, for example, a good piece of evidence showed that statin reduce the risk of cardiovascular effects by 25% relative, in relative terms, 25%. So if I apply this 25% for somebody of low risk, his or her NNT will be very high, maybe infinite, because that person over the next 5 or 10 years will not have a cardiovascular events. So you're trying to decrease 25% of something close to zero. So
yes.
The NNT is like infinite. But if you apply to somebody of 10% risk, you decrease in absolute terms 2.5. And 10 divided 100 divided by 2.5 is something like 25, right? Yeah.
40, right?
Sorry. Yeah, 40. So now you have 40. It's the specific NNT of this patient. Then you go to the third step, which is the values and preference of that patient, and also the risk or side effects. So
of course,
there are
unintended
three things.
So,
the rule that we should follow is the relative risk reduction. Apply clinically to individual. In this individual, it's 40. It's too much for somebody, and another person may think, "Wow, I want to
absolutely
to play this lottery."
Absolutely. And Lewis, I completely agree with you. And that gets me onto the issue of this top. Well, so there's one thing, again, I think one of the important things that we need to advocate for is also constantly questioning, you know. It shouldn't be just accepted as absolute proof that the NNT is 40, because there are limitations with all these studies. Often, you know, what we do in medicine when we're applying evidence to an individual patient is trying to fit, there's a saying, trying to fit a square peg into a round hole, you know, because often the patient in front of us doesn't reflect the characteristics, for example, of patients in clinical trials. So, you know, if somebody in a clinical trial, you know, for example, got significant side effects and may have been removed, you know, in the pre-randomization period, okay, let's just say that conceptually, you know, then that patient is not going to be, it's unlikely, certainly,
Right.
to benefit from a statin, right? Certainly that particular statin that was prescribed for them. And therefore the NNT, I'm just saying this as a concept, doesn't even apply to them. Now, the reason I'm saying that, and I want to have this discussion with you because I think this is interesting. When I go a bit deeper when I discuss NNT with patients, certainly in terms of benefits, okay? So obviously you're right about the relative risk reduction, but then for that individual, based upon their risk, the NNT may decrease, become more valuable. I say to them that if you take this pill on a daily basis, up to the length of the trial period, because we can only comment up to the length of that period of the trial that showed the benefit, say 5 years. If you do not get significant side effects, you know, you're not troubled with side effects, then the NNT for you is this. Now, I think that's important because, you know, and this hasn't really been properly tested in the real world, but I have my own view on it, is I suspect if you used all comers and took everybody, okay, and you know, and randomized them and didn't have any removal of patients or pre-randomization, you know, run-in periods, etc., I think the NNT would increase substantially. And that then is interesting, isn't it? Because, you know, we may eventually get to that information and data. I'm sure in time we will, Lewis. But that is an interesting also concept. And the reason that's also important is there is a fear amongst patients and amongst doctors, and I see this all the time in conversations I have, that even if a doctor genuinely believes a patient, say a patient with heart disease or heart attack, is suffering debilitating, you know, when I say debilitating, a side effect that interferes with their quality of life, and it may be that they are very fatigued and tired and got muscle pain, that they are scared. They are scared of stopping the pill, even for a few weeks, because they haven't understood the evidence and they think the patient could die. And obviously that is a big fear, and the patient has that fear. And it actually doesn't make any rational sense, because in my view, if a patient has got genuine debilitating side effects from statins, they are not represented in those clinical trials to the endpoint of preventing an event. And therefore, in theory, their risk of death is zero. We don't have any evidence on these people.
Right.
What do you think about that?
Yeah, I think that we expect too much of clinical trials. Clinical trials are made to prove the concept. And the relative risk, the relative increase of risk of side effects is always constant. So I can take this rule from a clinical trial and say, for example, if I use bleeding with anticoagulants, you know, the increase in risk of bleeding is like 80%. It's more actually in relative terms than the decrease in ischemic events.
Sure.
But the clinical trials, of course, and it should be like this, they will select patients with a better risk profile to test the hypothesis.
Absolutely.
But this
that is a limitation as well, though, Lewis, isn't it? And it's a limitation that isn't applied in practice.
We should, but it's not. It doesn't need to be a limitation, because we can take this 80% increase in risk of bleeding and apply to your specific patient that you know he or she has a baseline risk higher than the risk of the clinical trial. Okay, so the clinical trial is the laboratory. It must have a better situations, to ideal situations for the patient not to give up the drug or have a bleeding, because it's supposed to test efficacy.
Yes.
But we can take the rule from this, which is the increase in relative risk, the relative increase in risk of bleeding, and apply to individual patients. So still we can, I think we expect too much of clinical trials in terms of simulating reality. Clinical trials are to generate scientific concepts to be applied in an individual basis.
Absolutely.
And I agree that risk reduction or risk increase in relative terms should be in the mind of the physician, not in the mind of the patient. The physician takes it, applies to the baseline risk, calculates the NNT, and he or she will have creative ways to discuss with the patient the NNT in a better ways to the patient to understand.
Can I just add on that, Lewis, as well? I think that it's important to understand that even if we accept the 20% relative risk reduction in cardiovascular events with every 1 millimole of LDL reduction, which is something that has been imprinted on the minds of cardiologists and academics and lipidologists for a long time, again, based upon, I've got to be honest, non-transparent data with the Oxford Clinical Trials Service Unit. One thing we can say is that when you look at all other interventions, non-statin drugs, okay, this rule does not apply to that. And I think there is certainly question marks being raised, as certainly questioning the conventional cholesterol hypothesis regarding LDL. And I think we should explore that further with the data. We don't have all that data, but there is enough there to question whether this applies to LDL or whether it is something much more specific to statin.
In terms of LDL, if the LDL was almost normal, if it's normal, the effect size of statin therapy is lower. In this sense, the relative risk reduction varies. Because if you have a 100 milligrams, I don't know how to speak in millimoles, okay? I have to convert in Google. So 100 milligrams of LDL cholesterol.
It's about 3 millimoles per liter.
If you have 100 LDL, which is very normal, and you decrease to 60, it's the improved trial. The relative risk reduction is only 6%. So it's not true based on evidence that LDL is not an issue. If the LDL is very normal, is very low, the effect size is lower. If the LDL is higher, the effect size is higher. That theory, that thing was invented, was planted, in my opinion, by the industry that wanted to sell statin therapy as something better than reduction of cholesterol.
Yeah, Lewis, actually, I'm glad you said that, because
the data on cholesterol is very convincing.
The concept originally made sense, however, right? So I'm gonna back the concept of LDL reduction and where it came from, and see whether you agree with me. Is that when you look at Framingham and the Mendelian randomization studies, people with genetically, and that's another interesting thing. When I give my talks, I explain that most cholesterol, it varies from person to person. Most of your LDL is genetically determined. You can probably influence it, certainly in terms of by diet, maybe by 20%. But most of it is genetically determined, and people with genetically low LDL and genetically low total cholesterol tended not to develop heart disease. And at the other end, people with FH, people with genetically high LDL and high cholesterol, there was a significant increase in development of heart disease. Of course, that was less, it didn't seem to be apparent for the group in the middle, which is probably 90% of the population. But if you start with that concept, it would have made sense several decades ago. Okay, then what we should do is we should drive everybody's LDL through whatever mechanism and through drugs to get it as low as possible into the same category as the people who were found in the Mendelian randomization studies to have low cholesterol, to reduce heart disease risk. But the evidence tells us that has failed, because this is, again, you can't apply, medications have all sorts of different effects. We don't know whether there were different genes also controlling other factors that were going to cause heart disease or not cause heart disease that happen to track with low LDL. So I think that's interesting. So I can understand where it started from, but there is still many people, Lewis, out there, many academics who say, and a lot of them, I'm sure, the influential ones have very strong links to the drug industry. They want to push your cholesterol and say the lower the better, as get your LDL as low as possible. What do you think about that?
Well, the lower the better, but up to a certain point, side effects become more important than what you're getting from.
Yeah,
6% relative risk reduction is too tiny,
yeah,
so maybe it's not worth it. So, but in terms of proving a concept of cholesterol as one of the risk factors, not the risk
yes,
factor, I think the
yeah,
data is very consistent in terms of reversibility, that whatever way you reduce cholesterol, the risk somewhat reduced based on clinical trials. But I want to make the discussion more broad and say what we've been discussing here is some kind of overestimation of effect size. And we must understand now that modern medicine is not like 100 years ago when people invented antibiotics or insulin. Those things were magic bullets. What we invent now are good and should be used, but should be used with more rationality and
yes,
more economic thinking, measuring the beneficial effect against the cost. Cost may be side effects or cost for somebody who do not like to use medication. There are people who don't like psychologically to use medication. It's a cost, and also financial cost and everything. So we need to be much more economic, have an economical way of thinking nowadays, because effect size are smaller than in the past, and the magic bullets of the past. So it's all about rationality. But my question regarding you is, why do you choose statin therapy as your main discussion instead of a broad, like I have the impression sometimes that statin therapy, although you recognize the value of it, it's your pet enemy. And I know it was
yeah,
unfair, but some article of The Guardian accused you to be against statin, which is not true. But
yeah,
I have to recognize that sometimes it looks like you're against statin. So how do you
yeah.
defend yourself?
So the first thing is, I would say, Lewis, I'm against. We'll talk. I'll come on to specifically why statins has been the sort of one of my pet topics in a second. But what I'm against is not statins. I'm against lack of transparency in their prescription, and I'm against their overprescription, which I genuinely believe there is a big problem. Because I believe that if patients are given, even based upon the published evidence that we have, an understanding, I think many people would choose not to take the statin. If we go a bit deeper, for me, I started off. I've been now qualified doctor. I qualified in 2001, so coming up to almost 18 years. I've been specializing in cardiology probably for the past 10 years or so, since I was a senior house officer, and I then started to subspecialize in the hospital. So that cardiology is my bread and butter. It's what I love more than anything else. And when I started off my own campaigning or advocacy work, it actually was rooted in the fact that as a doctor, as a clinical doctor working in the National Health Service, I had started to feel over a number of years more stress on the system, more people coming in with more chronic disease, more people coming in more miserable, more effects on my colleagues and staff, because if the system is under pressure, then it's not the even the quality and the enjoyability of the work becomes compromised, and patients are going to be the biggest people that suffer. And I tried to understand what was going on, what was the bigger picture behind all of this. And tied to this, Lewis, was obesity. This is something that is affecting people globally now, that you have a massive increase in people becoming obese, overweight, developing and as a cardiologist, I try to identify where has this come from, what is the root of this. Now, one of the major roots for me has been this over obsession with lowering cholesterol. So I've looked at that. So what again, where did this come from, and what has been the indirect consequence? And that brings us to the well-known, accepted, certainly amongst people who understand the data, is that when you look at most people are being admitted with heart attacks now, Lewis, they have obesity-related, what we call metabolic syndrome, right? So 2/3 of people admitted with myocardial infarction fulfill criteria for metabolic syndrome, which is synonymous with insulin resistance. And I just want to then bring you back to a concept now, which might explain why there has been this focus on statins. There are lots of reasons I focus on statins, but one of them is the fact that let's take a scenario of a patient that comes in, okay, and the patient is prescribed a statin, and the patient's cholesterol is beautiful. They've got their cholesterol low, okay. They think it's fantastic. Yet the patient is overweight, is obese, is going out and eating junk food, right? So, and he becomes type 2 diabetic, not necessarily because of the statin, but because of his lifestyle, and has actually increased his risk of a cardiovascular event conceptually because he's developed insulin resistance syndrome. Now, if you look at the mathematical modeling studies, if you accept metabolic syndrome as a big, a cluster of risk, then actually it's the most important risk factor for coronary artery disease. So indirectly, by just focusing on a statin without that holistic view and saying you take the statin, he has been given the illusion of protection. Let's say his cardiovascular risk is low, and therefore there is no strong evidence of significant all-cause mortality benefit, and maybe no evidence for cardiovascular death reduction. He has indirectly increased his risk of cardiovascular disease. And not just that, he's increased his risk of probably misery, right? So there's another concept we don't discuss enough of. A lot of the clinical trials are designed to look at hard endpoints. They do not take into consideration patient preferences and values in terms of what should be part of the outcome measures. And when we're trying to manage this burden of chronic disease, if we just focus on hard endpoints, heart attack, stroke, death, and we leave out quality of life, that's something else which is a big limitation. Yeah. So actually, from my perspective, we have caused an overall, in this particular patient, this may apply to many people to different degrees, an overall net harm. And statins is a very good example of overuse, and it also perpetuates this over-obsession with cholesterol lowering, and in my view, detracting from new ways of thinking about why have we not still, Brown and Goldstein, the Nobel Prize winners, who determined that LDL was part of coronary plaques, etc., and certainly the associations with familial hyperlipidemia. They predicted in the mid-90s that we would end heart disease within a few years, right, because we should focus on lowering cholesterol. That was the main focus. It has failed, Lewis.
In the year 2000, because
it's about new ways of thinking, and it's about and at the moment, you're right about one thing. You tweeted something, and I think this is worth noting. We don't have any good randomized controlled trial data on lifestyle reducing hard endpoints. That doesn't mean it doesn't do that, right? Yeah. And this is an argument used by some people who say, well, listen, we've got this data on statins that shows it prevents heart attack, strokes, and death. We haven't got hard data on RCT evidence of that. That's because there haven't been really good design studies.
I think we should have.
But quality of life, though, Lewis, and lifestyle changes happen very quickly.
Enough. So it's enough.
And statins do not. Whatever they do, they may prevent some long-term event. But one thing they do not do, and I'm willing to be challenged on this, they do not improve your quality of life. And if you're unlucky to get side effects, they can only make your quality of life worse. And that applies to many drugs, blood pressure pills, drugs for type 2 diabetes, even worse. We have no all-cause mortality benefit. We have no reduction in cardiovascular death reduction, and we've got a multi-billion-dollar industry into drugs to lower glucose. Yet we have different dietary approaches. My view is certainly for, low carbohydrate diet is one of the best approaches and seems to be safe, effective, and seems to be the best approach with patient preferences and values. And that significantly reduces your glucose. Right.
I think
so this is where, for me, I think the other thing about statins is I still honestly believe there are many questions that still need to be answered, and we're not going to answer it in this discussion, about the reliability of the research and about the fact that really we haven't had independent analysis of that raw data, of the trial protocols, and there are many question marks, especially when it comes to side effects. And I think that I still want to pursue that and advocate for those questions to be answered. And until we get there, I will carry on being an advocate for that. But I'm not against the prescription of statins. I'm against lack of transparency in their prescription. And how can we improve the transparency and information on statins even further? I don't think that we have reached a complete conclusion on that
And
yet.
you know, I'm an advocate of being very critical about evidence and the quality of evidence. And in his book, Stagenka calls this the malleability of empirical methods. We defend things should be empirically tested and proved so we can believe. But we can actually, the methods are some kind of, we can change the method in terms of making a study a self-fulfilling prophecy. And I advocate strong skepticism before reading an article very carefully. Not only the article, but also looking at the ecosystem around it.
Sure.
If the things were predefined, the method of the study were predefined, about conflicts of interest, who is doing the study, and if the endpoints were changed afterwards and things like this. So we have to be very critical, but I don't think it is a specific thing about statin therapy. It's about everything, and
Absolutely.
And there are many things there are in practice that doesn't feel the level of evidence that statin therapy fulfilled. So,
yes.
So we should
Yeah,
recognize
Lewis,
that the quality
point.
of evidence is in terms of the concept is pretty good, but we can always question. And
absolutely. And one more point, Lewis. Let's accept. So listen, honestly speaking, I've said this before. If statins didn't have any side effects, okay, I would be advocating for them to be put in the water supply. Okay. I would.
Good.
Right. So I believe that there is definitely some benefit in and of course if there's no harm
at no cost,
then across the population. But you see, there's something else that brings us on to, and I think it's just worth noting and mentioning because I think it's an elephant in the room, irrespective of people arguing about the data and the reliability of statins. There's one reality, elephant in the room, is that the amount of discontinuation of patients taking statins is extraordinarily high. Now, I can cite different bits of data. I'll just give you a couple of examples. The largest survey in the United States, called the Statin Usage Survey, reveals that 75% of patients prescribed statins in the community will stop taking them within a year, and most of those say it's because of side effects, mainly muscle symptoms. But on that note, it's worth mentioning that, and I've been one of these doctors, so I know, I never, when prescribing a statin, actually talk about the potential side effects. I never did it in my clinical practice in hospital. I would say this is a life-saving pill. Please take this every day. It will prevent a heart attack. There was no discussion of NNT, but I would never mention side effects. Okay, so this is
for your patient, you don't fabricate the nocebo effect in your office.
You don't. Okay,
but
exactly.
I'm sure it's very well fabricated in the popular, conscience.
It may well be. I'm not denying the nocebo
kind
effect
of
exists,
prejudice against statins.
But that's a huge number of people stopping it, and this is before any media awareness. Now, the second thing is, I even go back, I can cite a paper in JAMA, 2002, retrospective study looking at several tens of thousands of patients over 66 prescribed statins with heart attacks. Okay, these are myocardial infarction patients, the ones that are going to benefit most. Lewis, 60% of those patients stopped the statin within 2 years. Yeah. There's something wrong, clearly. There's something wrong here.
I'd like to see a comparison. I'd like to see a comparison of this data with other drugs,
It's higher. It's much higher. Yeah. It's much higher. I can't give you the exact figures, but it seems to be much higher. I think with blood pressure pills, I know patients check their blood pressure, they take their pills. Of course, there's a 10% side effect rate, which is accepted, whether it's ACE inhibitors causing dry cough or ankle edema from calcium channel blockers.
People fear blood pressure, high blood pressure, much more than high cholesterol. If somebody feels anything, they will take their blood pressure.
Exactly.
So there's a fear. I think
I think the interesting thing is when you ask the patient, we as doctors have to ask our patients, right? Why? And when you ask the patients don't lie. They say, and they know it. This nocebo effect, I have no doubt exists, Lewis, but this is, it's a nonsense that people are saying this is the main cause.
I agree.
It's absolute, and it's, it's an injustice. And I think it's an injustice to our patients, and it's insulting to many patients who have suffered significantly,
Right.
who feel that their voice is not being heard. And I have it all over my Facebook page. These people are genuine, and we have to listen to these patients.
Right.
Really have to listen to them, right?
And
That's
the
all I'm saying.
decision, as we think probabilistic, it's not exactly a bad thing to take off the statin from the patient, because the NNT for that patient is 30. So he or she can be 29 out of 30 that would get benefit. So it's very much okay not to insist on something that is not good for the person.
I'm just highlighting, there are a few questions I think they're interesting stuff, and I think there is more research to be done, more hopefully more access to some of the raw data of these trials, the clinical study reports, the individual cases. We can maybe have a better idea. And of course, in terms of side effects, there are a lot of differing studies, observational studies, etc., in terms of the incidence. But I think that at the very least, there's a very interesting paper that was published online on the American College of Cardiology website called "Statin Intolerance Not a Myth." Mm-hmm. Their own estimates are about 10 to 15%. But again, they also identified, and this is useful for the individual doctor, Lewis, as well, because the more information we have, the more, I think the more we can treat our patients better, is that they identified several groups of patients who are in significant increased risk of getting side effects. And those groups of patients are actually a significant proportion of the population. There were people who were over 70, people who had a low BMI. It applied to women. It applied to people of Asian ethnicity. It's a huge cohort of the people that we treat.
Yeah.
So a lack of knowledge and awareness of this, in my view, also will stop many doctors recognizing a genuine side effect of statins. And if they have multi-system, multi-organ effects, again, conceptually, this happened even with some of my patients. If the doctor is not aware, so I remember something being taught in medical school. If you're not aware of something, even if it's rare, you'll never diagnose it. If you're not aware of a cause of something, of a condition, or a cluster of symptoms, you will always miss it. Just think about that as a concept with statins. If the patient comes in, I had a patient, for example, I wrote about this in several years ago, and a patient who had disabling chest pain. Now that again is it seems to be, or certainly a rare side effect of statins. Disabling chest pain. I had a stent, had an MI, evidence-based therapy, high-dose atorvastatin, and he was, we sent him for a repeat angiogram. There was no evidence of any restenosis. His stent was patent. I then prescribed him a proton pump inhibitor. I thought maybe this chest pain he's getting is acid reflux, so I gave him a proton pump inhibitor. It didn't help him. His GP then referred him for an endoscopy. Okay. Now, during all of this, he comes back to see me in clinic. He's miserable. He also mentioned some muscle pain. I thought maybe it's a statin. So I stopped the statin for a couple of weeks. 1 week later, Lewis, after 3 months of disabling, and he was skeptical, by the way. You talk about nocebo effect. This man was skeptical. He said, what's it got to do with my statin? But fine, doctor, I'll do it. 1 week later, all his symptoms resolved. His chest pain, his muscle symptoms, completely resolved. Now, because he didn't even think about this possibility, he would have gone through so many other investigations. For what reason? At the end of the day, the most likely probability is it was the statin causing the symptoms. So I'm again just introducing that concept, is that if we think that the side effects are so rare or non-existent, which many of us have done for many years, okay, very rare, less than 1%, then we're going to miss it. And how many people on a population across the world, 100 million people are estimated taking statins, Lewis, if the true rate of side effects, which are reversible, I've got to be honest, in most cases are reversible and not life-threatening and not going to, but certainly interfere with the quality of life, if that's affecting up to a third, with some estimates suggest a third of patients, how many of those people's quality of life, how many of them are living in misery, and how many of them are being sent for unnecessary investigations for symptoms that the whole time were due to statins? And if that is true, that's staggering. That's a staggering waste of healthcare resources.
Yeah.
And it's really I would say an injustice to our patients.
Right. I think that this discussion is very interesting. It's about economic way of thinking and measuring also the cost to the patients of everything we do. So you emphasize that for some patients the cost of taking statin might be higher than we think, but it has nothing to do with denying the beneficial effect of statin. And you
No, of
just
course.
said you would
Absolutely.
put
Absolutely. So it's
in the
again a holistic
water
view.
if,
Holistic view.
if
Yes,
there's
absolutely.
no
I'm not, and
beneficial
listen, I'm
effect.
glad you said that.
So the
We're
proof
not
of
trying to deny the
concept is
beneficial
there.
effect.
Cholesterol is a
Yeah.
problem and it's beneficial. But I think we should have this way of thinking with everything. For
Yes.
example, antidepressant, it's a much bigger issue because there's no effect to mild or moderate uh, uh, depressive disorder, and the
Yeah.
side effects are higher, much higher than statin side effects. So I
Yeah.
think we should take this example in general, but not
Yes.
denying, and that's what people who criticize you couldn't understand. You're not denying the beneficial effect. You're just
Not at
trying
all.
to promote a more rational way of thinking.
Lewis, I calculated I have probably in my career I've actually, if you think about, working in an acute hospital at the NHS, during some weeks for several months, I would be, the turnover in the hospital, these days, people come with a myocardial infarction, they get the turnover, they're in hospital in 2 days, okay? Doing ward rounds as specialist registrar, we would have a turnover of maybe 20, 30 patients every fortnight. I mean, it would be very rapid, okay? And if you translate that, outpatient clinics, I've managed tens of thousands of patients in my career, and thousands of those have been people with heart disease, and I've prescribed statins to thousands and still do so. Okay, so that experience is there, and that's something but again, I've evolved my thinking
Right.
about how to approach the prescription of these drugs with the patients, with a shared decision-making conversation, and that's basically what it comes down to.
We are already talking for 35 minutes, and we could be talking for another hour. And so I want to do another talk with you about another issue next time, which is your next book. And
Fine.
I understand it's a book
Let's
about rationality and things like this.
Of
Because our
course.
talk, we took the statin problem and things like this just to exemplify the rational way of thinking. We
Sure.
are both
Absolutely.
advocates for this, and this is our bond. And regarding bonding, I was reading about the bounded awareness. Bounded awareness is when your awareness is focused on one thing, maybe cholesterol, and you forget the obesity problem. So we should not only focus on one thing, but in general.
Yeah.
And so it's not only about this or that therapy, it's about the medical field and a more rational way to think. And we are both in this direction. You have the last words. Thank you very much for talking to us. I think we are going to do it again and talk more because there are many
I
issues we
look forward
didn't
to that,
cover.
Lewis. It's always good to chat to
But
you. And again, I think we both have to also, we bring different things to the table, and it's really good and important to keep challenging each other and amongst the profession, to engage in these healthy scientific debates. We need more of this in modern healthcare. And unfortunately, there are certain groups of people, maybe old-fashioned thinking, that don't appear to be so open to having these open discussions.
right.
So we need more of this, for sure.
Thank you, Aseem. See you next time.
All right. Thanks, Lewis.